So our next speaker is from Australia. Please welcome Ashley Crook to the platform.
Thanks very much. So before I start, I just wanted to acknowledge that I've been funded to come here today by the Motor Neurone Disease Research Institute of Australia. I've conducted a research grant this year, and there's some quotes from that research in today's talk, and I have a poster tomorrow night as well. I've outlined the expected outcomes and disclosures initially. So the first expected outcome is about the fact that results of genetic testing do not currently impact on patient care. So unlike other aspects of multidisciplinary care where there's impacts on survival and quality of life, results of genetic testing currently do not do that. And I guess that's important to keep in mind as I work through the slides today. It's also very possible that things might change in future. There's potential therapy trials that might be specific to people with certain mutations that might come up in the near future. Despite all of that, genetic testing and counselling could be beneficial to familial and sporadic ALS patients and their families. And genetic counselling by an experienced genetic counsellor or equivalent could be a valuable addition to a multidisciplinary team. So just about the multidisciplinary clinic at Macquarie University Hospital, we run this clinic twice a month, and we have a range of different specialties who attend the clinic and who also can meet with people outside of clinic hours. So I've been working in the team for just over 2 years now, and I work both within the multidisciplinary team and also in the general neurology practice. So this is a quote from Martin Turner recently published, which summarised the fact that even though genetic testing does not impact on clinical care, he suggests that it is recommended to be a part of routine clinical management now by saying the practice of refraining from any discussion of genetic testing should now be challenged as an unnecessary limitation to the provision of best care in ALS and FTD. Genetic counselling itself is something that's not just done by genetic counsellors, it's done by a range of different health professionals. And it's not just about information giving, it's really about helping people to adapt to the genetic information that comes up, whether that's from genetic testing or just from a family history of disease. It's about promoting informed choices about genetic testing and other medical decision making, increasing personal control while minimising psychological distress. And the really important point to make is the goal of genetic counselling is not to reduce inherited disease prevalence. So it's not my job to tell people how they should and should not have children. It's not only about the patient in front of you though, it's about family-centred care too. And I guess this is highlighted in one of my research quotes from Laura. And I'll just mention that pseudonyms are used throughout this talk. So Laura says, after 6 months of keeping the test results to ourselves, my husband and I made an appointment with a genetic counsellor. We found this extremely helpful. We came away from the consultation knowing that we should tell our 3 adult children. I feel a sense of relief having told them, although it has now left them with decisions to be made either now or in the future. This is just a quick slide to demonstrate the fact that genetic testing technology is constantly improving, and therefore our ability to detect ALS-related genes has improved significantly in the last 25 years, with a big increase of gene discovery in the last 7 or 8 years. And the biggest, most common genetic change in ALS is the C9orf72. So what we know is that around, in Australia, 10% of cases of ALS are familial and around 90% are sporadic. And this differs between populations studied, but it's also worth mentioning that there is actually no agreed definition on what constitutes familial and sporadic disease. So even in Australia, different families who attend different services would be classified differently depending on whether they're familial or sporadic. And this is particularly important when we're looking at families where there might be a person in front of you with ALS and a more distant relative with ALS too, and questioning whether or not that could be genetically related or not. When we think about familial ALS, our pickup rate sits at around 60% if we were testing all ALS genes. So that means about a third of people who clearly have familial ALS actually don't have a gene mutation known or found using current technology. The flip side of that is that people with sporadic ALS may also carry a gene mutation. In Australia, we pick up around C9orf72 in around 3% of sporadic cases, but that's been reported as 10% or more in other case reports as well. So I'm just going to work through this slide on the clinical genetic testing process, and usually the genetic testing process starts with an ALS patient, looking for a mutation within them to explain why they developed disease. And of course they could decline a test, but if they go ahead with testing, then either a mutation or variant is found or not. If they decline the test, or if no mutation is identified, then their family members may still be at risk, but there's no testing available to them because we don't know what we're looking for. If a causal gene variant is identified, however, other family members could undergo predictive testing to determine whether or not they've inherited that gene fault. And I guess when it comes to predictive testing, the thing is that you might know that you're a carrier of the gene fault, but it's very hard to predict if, when and how it will affect you. And most people actually decline predictive testing. In our Macquarie University clinic, about 13% of first-degree relatives and less than 1% of second-degree relatives actually go ahead with testing. If you do go ahead with testing, however, you either get a positive or a negative result, and the negative result is the one you want, where a gene variant is not identified. So I guess in the next step, if someone does have a mutation identified, then they can consider reproductive options to prevent ALS being passed on to the next generation. I've just highlighted some of the options here, and I want to emphasise the fact that these options aren't available everywhere. And although it is the only means to prevent ALS in a person at this point in time, none of these options are particularly easy or straightforward. The options vary from choosing not to have children, or choosing not to have biologically related children through adoption or donor sperm, egg or embryo through IVF, or going through IVF and testing embryos before they're implanted, which comes with limitations in terms of success rate and also significant costs. And then the final option there being the prenatal diagnosis, testing a pregnancy and then opting to stop the pregnancy if the mutation's present. So I guess that's what I have in mind and what we talk to people about at different stages of where they're at. And as I said, what we know is there's no agreed definition of familial versus sporadic disease. There's also no agreement on who we should offer testing to, how we should test and what to test. And that's something that's not about, different countries and different rules. It's about from doctor to doctor about what is and is not offered. There's certainly been a bit more of a push to consider doing more testing, and that's probably based on the fact that ALS patients have a high interest in diagnostic genetic testing, and it could be useful information for the rest of the family. As I said, I've just skipped forward a bit. The uptake of predictive testing is low, but most people cope well, and probably the reason why people cope well is because it's quite a strict process to go through predictive testing, currently with multiple appointments to determine whether the timing and the risk benefits and limitations have all been considered. So I've got a case example here of Diane, one of our multidisciplinary care patients, who comes to the clinic with her family, and she comes with her son Simon and daughter Emma. So I guess in this situation, when I met Diane quickly in the multidisciplinary clinic, there was no significant family history, but on asking a bit more from her, she did mention that her mother had frontotemporal dementia, which does raise the question of whether she might have familial disease. In speaking to Diane, I explored with her whether there was any way she could gather some more information about the family history and wondered whether she could speak to anyone in her family. She's not in contact with her cousins, she's in very little contact with her siblings, but she can contact Uncle Fred. She spoke to Uncle Fred, and in fact there is a family history for both MND and frontotemporal dementia in his maternal relatives. So I guess that demonstrates that, asking the right question means that you can gather a bit more family history information. And based on this family history, we discussed with Diane the fact that she could well be a part of a familial ALS family and the option of genetic testing. So she attended the appointment with her son and daughter, and Simon was very keen to undergo for Diane to undergo genetic testing because he wanted to know if there was a test available for him, mainly for family planning reasons. Emma, on the other hand, was not at all interested in knowing whether there was a known genetic mutation, and she didn't want to face the possibility of making a decision about genetic testing at a time when she's caring for her mum. So we talked about all of the options around that very briefly at the multidisciplinary clinic, but really it gave us the time to meet with Diane, gather some further information, and then arrange to meet with her separately with Simon and Emma to talk through their decision of making a bit more. And decision making is complicated, so I've highlighted here some of the factors that impact on the decision to be made, and there's certainly a range of different things that come up for people. And I guess not only is the decision making complicated, sorry, I'll skip through this as well, it's also complicated by the genetic testing technology. So the next example I have is of Simon, who was referred to me with MND and a brother with MND, too, seen at a separate clinic. So both of them already were found to have a SOD1 gene mutation, and this fit quite well with the fact that there was multiple family members with MND and the possibility of MND in their father and paternal grandfather as well. So Simon was referred to me to talk about genetic testing for his adult children and really to meet with him as an initial step in that discussion. So what was found in Simon was this particular gene mutation in the SOD1 gene. And part of my job is not only speaking to the patients, but also looking at the genetic variants involved. And I guess before I meet anyone with any genetic testing results, it's my job to look, could this change be causative of disease, or could there be something else? And I guess there were some papers in 2010 which suggested that this particular genetic change did not necessarily segregate through familial families with disease. Even though it's been reported as a mutation previously, it did raise questions about whether or not this is actually a change that's causative. And in reviewing this result with other laboratories and other team members, we agreed that this was actually not enough evidence that the SOD1 gene mutation or variant here was causative of disease. So even though it fits with the family history, we have to have an attitude of being suspicious, because when people are making decisions about testing for children or reproductive decision making, it's really important to work through those things. So part of my job then was meeting with Simon and actually explaining to him that the current knowledge around this was not as confident as we used to be, and working with him through other testing options and, just speaking to his children anyway about the fact there is likely to be familial MND, even if the gene mutation's not detected. So in terms of my role, there's a range of different aspects here, and it's a variety of different genetic testing, including research aspects. Also support, advice and counselling that doesn't involve genetic testing for both associations and by telephone. There's a whole bunch of technical analysis, but in addition to that, there's also, looking at different ethical aspects that might come up in conducting research, genetic testing, for example. So these are the conclusions which I've covered previously, so I'm going to stop here, and I'm more than happy to hear from you if you have any questions or wanted to have a chat to me more about what I do. Thank you.
Thank you, Ashley. So we have time for questions. Please raise your hand and a mic will come to you.
Hi, thank you. My name's Ellie. I'm the genetic counselor at Columbia University in New York. When you had the diagram of the clinical genetic testing that's offered, is it just C9 or is it a panel of genes?
So I guess that was just a theoretical process. So what we do at Macquarie is we can offer C9 or 72 to anyone, both familial and sporadic, and then those who are interested and also those who have familial disease that might suggest there's another gene change involved would then go on to do further testing, whether that's a panel or a single gene mutation search, depending on the family history.
Okay, thanks.
Thank you. Any others?
Hi, my name is Mongchi Shah. I'm from Boston area. I'm an advocate for integrative care of ALS patients. I'm really happy to see that you give this presentation. Among the patients I have encountered with familial history, some patients, even with the exact same mutation, can develop the disease in the 70s or even never develop the disease. So I think we really need to nail down. I believe SOD mutation is a risk factor and not a causative factor of the disease. So if we modulate the inflammatory response in that particular person, that we may have a chance to really delay the onset of the disease, or may never even happen. So I think when the person gets the confirmation that they have the gene, it's a mental burden that can potentially trigger the early onset of the disease.
Yeah, and I guess that's certainly a part of the pre-test counselling is talking about the burden of knowing and the fact that there is still uncertainty around it. And certainly you're absolutely right, there's so much we don't know about the genetics of ALS, and that's something we emphasise with patients too, that our knowledge is constantly changing and that this is not necessarily a 100% risk, and that the future options like looking at different treatments and management might be useful.
Okay, thank you, Ashley. I need to close it down because we need to move on. So join me again in thanking Ashley for that presentation.